Today I am going to present topic on bisecting angle technique or short cone technique. First we are going to see about indications for periapical radiographs, reduction of apical inflammation or infection, assessment of the periodontal status after trauma to the teeth and associated alveolar bone, assessment of the presence and position of unerected teeth, assessment of root morphology before extractions, during endodontic procedures, preoperative assessment and postoperative appraisal of apical surgery, detailed evaluation of apical cyst and other lesions within the alveolar bone, and then evaluation of implants postoperatively. Then principles of bisecting angle technique. Bisecting technique is based on simple geometry rule of isometry, which states two triangles are equal if they have two equal angles and share a common side. The dental radiographer must then direct the central beam perpendicular to that of imaginary bisector. When the central beam is perpendicular to that bisector, two imaginary congruent triangles are formed. When these principles are followed strictly, the tooth image 1 second accurate. The receptor is positioned as close as possible to the lingual surfaces of the teeth, resting in palate or in floor of mouth. The orientation of receptor teeth central ray increases geometric distortion and presents teeth and supporting bone more coronally than its normal anatomic position. Then film holding devices. Film holders are recommended so that the patient does not have to hold the film themselves. This reduces patient's exposure and the possibility that the film might shift around when being held in place by the patient's finger. Some film holding devices used for bisecting angle technique are RIN BAI instrument. It works like XCP except it is defined for the film to be placed closer to the tooth surfaces. Then positioning of the patient. For maxillary projections, the patient should be seated upright in the dental chair with the sagittal plane vertical and the occlusal plane horizontal. For mandibular projections, the patient should be seated upright in the dental chair with the sagittal plane vertical. The head is tilted back slightly to compensate for the changed occlusal plane and the mouth is opened. Then receptor placement. Similar to the paralleling technique, the receptor is positioned behind the area of interest with the apical end against the mucosa on the lingual or palatal surface. The occlusal or incisal edge is oriented against the teeth with an edge of the receptor extending just beyond the teeth. If necessary for the patient's comfort, the anterior corner of a film can be softened by bending it before it is placed against the mucosa. Then angulation of the head. For horizontal angulation, when a receptor holding device with a beam localizing ring is used, it facilitates alignment with the X-ray beam so that the central ray is directed through the conducts in the region being examined. If the receptor holding device does not have beam localizing feature, the tube is angled in the horizontal plane to direct the central ray through the conducts. The edge of the X-ray beam collimator cone should be parallel to the buccal surfaces of the teeth being examined. Vertical angulation. In using the bisecting angle technique, the goal is to aim the central ray of the X-ray beam perpendicular to a plane, bisecting the angle between the receptor and the long axis of the tooth. Now we are going to see about projections for the teeth. There are two projections given by North America and India. First we are going to see about North American projections for maxillary and mandibular teeth. For incisors, plus 40 degree; for maxilla, for mandible, minus 15 degree. For canine, it is plus 45 degree. For mandible, minus 20 degree. For premolar, for maxilla, plus 30 degree. For mandible, minus 10 degree. For maxillary molars, plus 20 degree. For mandible molars, minus 5 degree. According to India, maxillary incisors, plus 45 degree. Mandible incisors, minus 25 degree. Then maxillar canine, plus 45 degree. Mandible canine, minus 20 degree. Then maxillary premolar, plus 30 degree. For mandibular premolar, minus 15 degree. Lastly, for maxillary molars, plus 30 degree. For mandible molars, minus 10 to 0. Then why do we use the bisecting technique? Here is the answer I mentioned below. When dealing with the patient who has difficult or unusual anatomy, when the patient has a disabling condition that may prevent them from closing on a bite block, when dealing with an uncooperative patient such as small child, then used with certain endodontic films. At last we have to see about disadvantages. The many variables involved in the technique often result in the image being badly distorted. Incorrect vertical angulation will result in foreshortening or elongation of the image. The periodontal bone levels are poorly shown. The shadow of the zygomatic buttress frequently overlays the roots of the upper molars. The horizontal and vertical angles have to be assessed for every patient, and considerable skill is required. It is not possible to obtain reproducible views. Coning off or cone cutting may result if the central ray is not aimed at the center of the film, particularly if using rectangular collimation. Incorrect horizontal angulation will result in overlapping of the crowns and roots. The crowns of the teeth are often distorted, thus preventing the detection of proximal caries. The buccal roots of the maxillary premolars and molars are foreshortened. That's all. Thank you.